My name is Elena Nazareno and my topic is randomized trial of endoscopic or open vein graft harvesting for coronary artery bypass. Definition. The saphenous vein graft is the most common conduit for coronary artery bypass grafting, CABG. The influence of the vein graft harvesting technique on long-term clinical outcome has not been well characterized.
Outcomes in terms of major adverse cardiovascular events in patients who had saphenous vein graft harvested endoscopically versus open in a randomized trial. It also showed that there was reduced risk of wound complications in the patients that had endoscopic harvesting. I think this trial opens the question for further investigation, a larger study, more patients of diverse not only gender, as this study was largely male, but also a larger group of patients with multiple comorbidities who may have had multi-vessel disease. So I think it opens the question for further study. Any longer-term follow-up we could have would be beneficial. In addition, data on patency would also be very helpful. The use of one arterial conduit is now a quality measure and is mandated, and that data is publicly reported for surgeons. So we know that the use of the left internal mammary artery to the left anterior descending should be done in all patients, if possible, undergoing coronary artery bypass grafting. And there are a lot of data now that suggests arterial grafting is beneficial to survival and for patency over the long term. So the longer term data that we would have, the more information we would know. However, vein grafts will always be in our armamentarium if arterial grafts are insufficient or inadequate, or for example do not provide adequate flow in an emergency situation. So we will always want to know, would it be better to harvest it open or endoscopic or with small bridging incisions. Different surgeons are driven by different motivational factors. Time is one of them, whether or not they believe the data, the literature, and that arterial grafting provides prolonged survival and better patency compared to vein grafting. Also, many of us work at teaching institutions and
nursing application. The nursing staff acts in the development of the operation, helping the surgeon or maintaining order in the operating room. It also provides support to the patient in the preoperative period. The nurses receive the patient and help to place them on the operating table depending on the type of surgery that will be performed. The instrumentalist nurse, after performing the surgical handling, begins to prepare her surgical table with all the necessary material for the surgery.
You saw this patient, you bring him into the OR, you fix them, and you take them to recovery. I always like the immediate gratification of seeing somebody get better.
We do assessments, we do documentation, we administer medications, we do everything that all nurses do. We just have to do it in a very short amount of time.
I think the best part of my job is being able to be someone's lifeline. They're absolutely terrified prior to surgery, and being able to be that someone's everything, it just takes your breath away every time.
Pros and cons. Pros. The intervention of the nurse had its great advantage. Science is the novel in the surgical act is very important to avoid unwanted complications. Cons. Ignorance of effective techniques and lack of vocation in practice can lead to many complications such as surgical site infection, prolonged stay, among others.
A typical day for me is coming in the morning about 7 o'clock, and then I figure out which room I'm going to be in for the day.
So we're in operating room 2. This is a room that we use for add-on cases that are not scheduled, cases that come up, be it from a patient that's on the floor or a patient that's in the emergency room.
On a typical day, we run 15 rooms. One of those is including the emergency add-on room.
Working in an operating room is really, it's a team concept. So I'm constantly working with people. There's an anesthesia provider, there's a surgical tech, there's a surgeon, there could be a first assist, or there could be a surgical PA. So it's always a group project to perform the case and to get the patient out safely. We usually see the patients anywhere from, I would say, 7 to 15 minutes a week. We go over what our role is with the patient. So we're in the room with the patient the entire time they're under anesthesia. We're their watchdog.
I think people are usually very nervous about having a procedure done here. It is their most vulnerable time because you are their patient advocate, and I think you just have to talk to them nicely, and you have to build that rapport with them right off the bat when you go to meet them and do your initial interview.
I also walk them through what's going to happen so that they have an idea, so they're not like guessing, what's coming next. After each case, we do a turnover, which we have a turnover team that comes in, the ORAs. They will wipe everything down. It's actually a group effort. The nurses, the scrub techs, we all come together and wipe all the equipment down, wipe the bed down, wipe the lights down, mop the floors.
Keeping an area sterile in the OR is very important. We have EVS that work throughout the night that terminally clean our rooms so that when we come in the morning, our rooms are fresh and clean.
I came right out of nursing school. I'm a brand new grad, and it's been great. I've had a lot of great resources, and it's been quite an experience so far.
I plan to continue my nursing career here because they build you up, they allow you to grow. There are scholarships available, there's tuition reimbursement available for you to go back to school.
New grads, I would say, would have a very good experience coming in to GBMC, especially the operating room, because I feel like you have a lot of resources. It's a very open community or group of nurses, scrub techs, all the providers. Everybody was very welcoming.
I come here both as a patient and as an employee. So my primary care is here, my orthopedic physician's here, my wife's OB is here. I feel like it's a place where they really do practice what they preach, which is treat every patient like they were family.
Application in Ecuador. This type of surgical intervention are performed in specialty or specialized hospital in large cities of Ecuador. Since a failure in the smaller technique could complicate the patient's life.
Hello, my name is Faisal Bakian. I'm a staff cardiothoracic surgeon at the Department of Thoracic and Cardiovascular Surgery at the Cleveland Clinic. Today we're going to talk about the results of the regroup trial. It was just presented at the American Heart Association, and simultaneously the manuscript was published in the New England Journal of Medicine. This study randomized patients undergoing coronary artery bypass grafting or CABG into veins harvested either endoscopically, meaning with the help of an endoscope and small keyhole incisions to harvest the veins from the leg, versus the traditional open approach, which typically involves skin incisions separated by bridges and sometimes, out of necessity, a long skin incision. And the impetus of the study was really the question that was lingering in the cardiovascular community about the safety and efficacy of using less invasive means of taking the vein, which continues to this day to be the most common conduit used to supplement the left internal mammary artery bypass to the left anterior descending artery. And there was a question of whether using a minimally invasive technique with an endoscope would harm the vein and result in bad outcomes. And it really dates back to a study in 2009 published in the New England Journal of Medicine, which was a post hoc analysis of the PREVENT-4 trial that was designed to answer something else. But in fact, the post hoc analysis showed worst clinical outcomes in patients receiving endoscopically harvested veins. So this raised alarms in the cardiovascular community about whether we should be using the endoscopic minimally invasive technique or whether we should revert to the open skin incisions. The problem with the open skin incisions is that they're cosmetically less appealing, obviously, because you make big skin incisions, but also there's a higher incidence of wound infections and wound complications related to those bigger incisions, and a compromise was to do smaller skin incisions separated by bridges. So the regroup trial is the largest multi-center prospective randomized trial on this subject that we were part of. In fact, I'm a member of the steering committee. We randomized 1,150 patients to either receive an endoscopically harvested vein or a vein harvested through skin incisions, and we tried to minimize those skin incisions, as I said, and separate them with skin bridges. The median follow-up of the patients was under 3 years, and the primary outcome measure was the major adverse cardiovascular events. Now, the study results were negative, meaning that patients who received veins using the endoscopic technique had similar outcomes to patients who received veins harvested through traditional means. In other words, there's safety to the method of using minimally invasive endoscopic harvesting. So that was a big sigh of relief for the cardiovascular community. And as expected, actually, there was less incidence of wound complications and leg wound infections in the group of patients that received endoscopic harvest. So there was incidence of just over 1% of leg wound and complications and infection in patients who underwent endoscopic harvest versus over 3% in patients receiving open traditional harvesting technique. Now, one point, actually 2 points that I want to raise here is first, the study emphasized the importance of the experience of the harvester, meaning that you can't be a novice endoscopic harvester to harvest veins for patients enrolled in this study. So you had to be a competent endoscopic harvester and a competent open harvester. So those results are representative of this kind of medical team taking care of you, experienced medical care team. Another point I want to raise is, at the Cleveland Clinic, we've always thought that using more arterial grafts can be beneficial in selected group of patients, and we have demonstrated that using bilateral internal thoracic arteries and multiple arterial grafts, such as the radial arteries, can be of benefit to patients, specifically in terms of prolonging patient survival. And the benefit usually kicks in many years after the procedure. So we're not just interested in immediate outcomes, we're interested in long-term outcomes and for our patients to have a durable operation with excellent quality of life. So our approach at the clinic is to use arterial grafts to supplement the left internal mammary artery to the LAD whenever possible to enhance the longevity of the patients. And in patients who would require saphenous vein supplements, we use minimally invasive techniques such as endoscopic saphenous vein harvest, and we have excellent outcomes using that technique. And this study really validated our approach. Thank you for your attention.
Conclusion. Among patients undergoing CABG, we did not find a significant difference between open vein graft harvesting and endoscopic vein graft harvesting in the risk of major adverse cardiac events. Thank you.